So let's go over some of the anatomy quickly. Like I said, we're going to skip the mouth and the teeth, and we're just going to start with the lower GI. So that includes like the esophagus, the stomach, the large intestine, small intestine, and the rectum. So here you can kind of see like the layout of where everything is. You got the liver on the top left there. The liver is in charge of filtering the toxins out of the blood. You got the stomach. Obviously, it's where the food goes that you eat. There's stomach acid in there, helps to digest that food. Once it leaves the stomach, it goes into the duodenum. It's not labeled in this picture, but also not that one. You can see this part right here comes, the immediate part right after the stomach is that duodenum. It's the very first part of the small intestine. And the small intestines are here, and then once it gets to like the bigger intestine, the large intestine, that's what they call the colon. So when people have like colonoscopies, that's what they're looking at, is like the large intestine. Then we've got the rectum and anus, and then this is a little bit of a zoomed in picture of what the liver, pancreas, and gallbladder. So the liver, right underneath the liver is the gallbladder. It's that green little sac. And then you have the pancreas. We know the pancreas from the endocrine chapter, which helps regulate blood sugars with insulin and that sort of thing. So it is an endocrine organ, but is also a digestive organ. The pancreas also releases digestive enzymes as well. So insulin for sugar regulation, and then amylase and lipase to help with digestion. So this is just kind of like what they look like and where they are. This also wanted to show you, because a lot of times in like doctors charting, they'll refer to different regions of the abdomen. And if aren't familiar with those, you might not know what they're talking about. So this is just kind of a picture of like, if you've seen the doctor's chart talking about the epigastric region, you'll know like, okay, it's the top middle type of thing. Sometimes they also just call it like the upper quadrant, middle quadrant, or like lower quadrant. So I just wanted to show you this because it's common in charting. So you might want to understand what they're talking about. A lot of the diseases, you'll feel pain in certain areas. So like, for example, appendicitis, like the pain is usually in the right lower quadrant or the right iliac. So just knowing that helps you to know what diseases to look for. All right, the first one we're going to start with is called gastroesophageal reflux disease. The acronym for this one is GERD, G-E-R-D for short. You'll often see GERD instead of the whole thing written out. So the big issue with GERD is that it is a constant reflux of stomach acid into the throat. Okay, so everyone has that at some point. They'll have some kind of reflux. It's a normal experience, but some people have it like a constant issue. And the problem with this is that the stomach acid is very harmful to the esophagus, right? It can burn down the cells and cause damage. So various symptoms, I'm sure you're familiar with them if you ever had a reflux episode. Belching with a feeling of burning afterwards. You'd like kind of burp up some of the stomach contents. People refer to that as heartburn, even though it has nothing to do with like the heart. It just kind of hurts in this general area where the heart also is located, because the esophagus and the heart are kind of like in the same region. That tends to be worse when lying down, and that's just because of gravity. You lay down and the stomach contents don't have to go up gravity to go up the esophagus. It can just kind of flow sideways. So it's easier for the bile to come up that way. Tooth enamel erosion is also a long-term complication. The stomach acid is meant to break things down, right? So if your teeth are constantly getting coated in stomach acid contents, it can start to break down your teeth and cause cavities and different things like that. So what's happening here is like, why is this happening? There is a sphincter on the stomach, and let's go back and look at the stomach real quick. Where the esophagus meets the stomach, there is a sphincter called the lower esophageal sphincter, which makes sense because it's the lower end of the esophagus. And if it starts getting loose or too relaxed, its job is to keep the stomach acid inside the stomach. But if it gets loose and relaxed, the stomach acid can come up into the esophagus. So that's what's happening here. Some medications can cause that to happen. Sometimes certain foods, like spicy foods, can cause that to happen. Pregnancy as well, just because you have so much pressure in the abdomen, it like pushes the stomach contents up. Same thing with weight gain, and then alcohol as well is harmful and damaging to the stomach structures. How do you diagnose this? Well, there is something called an esophagoduodenoscopy. And I know it looks like a scary long word, but if you break it down, it has the word esophagus in there, duodeno, which is short for duodenum, and then scopy. So scope is like has to do with looking like through a camera to see what it looks like. So basically what they're doing is putting a little camera down your esophagus to look inside the stomach and sometimes into the duodenum to see like what structures aren't working to diagnose GERD. So as for treatment for this, elevating the head of the bed, again, just using gravity to your advantage. So it's harder for the stomach acid to come up if you're sitting up. Antacids can help as well, stuff like Tums. People probably have taken Tums before if you have like a stomach upset. It just helps to neutralize some of that stomach acid so it doesn't hurt as much when it gets refluxed up. Also avoiding eating heavy meals right before bed. So again, if you eat a big meal and then you lay down, again, you're allowing gravity to work against you and have the stomach acid come up into your esophagus. So just trying to eat several hours before going to bed. And then there are two med classes. There are drug class called PPIs, which stands for proton pump inhibitors, and H2 blockers. These two drug classes have basically the same action. They basically just reduce the amount of stomach acid that's produced so that it's just not going to have an overabundance of stomach acid going up into the esophagus. Any questions so far about GERD? All right, here's a little picture. On the left, you can see the sphincter is closed, what it's supposed to do to keep the stomach acid in the stomach. And then on the right, where the sphincter is loose and relaxed, that allows the stomach acid to reflux up into the esophagus.
So is this acid reflux and heartburn, or is this reflux?
Acid reflux and heartburn are like what people in the street call GERD.
I know there's like two different ones that kind of like sound the same, but they do different parts. Are we gonna cover that, or is that just
This is the acid reflux heartburn. Heartburn is technically a symptom, like the feeling that can be from different things, but the reflux, this is the medical name for reflux, is gastrointestinal reflux disease. So, and it's due to, like I said, the sphincter doing that. Everyone can have an episode of reflux. That doesn't mean you have GERD, right? Like sometimes you'll eat something that just doesn't sit right, or you'll have something weird happen. You'll have some reflux, but that doesn't mean you have this problem. Does that make sense?
Yeah, so is there a difference between like acid reflux and acid reflux, or no?
Between acid reflux and acid what?
Reflux, like reflex and reflux.
Oh, reflux is the word. Reflex is not a thing. A reflex is like when you take that little hammer to your knee and you kick. That's a reflex. Reflux is the action of the stomach contents going back up into the throat. Does that make sense? Okay, and here's a picture of what that esophagoduodenoscopy looks like. They're just putting a camera down the mouth into the stomach to look around to see what's going on. All right, next one is esophageal varices. Let's see, so with the esophageal varices, you guys remember when we talked about the varicose veins in the legs in the cardiac chapter? Where they had the little twisted veins in the lower legs? It's basically the same idea, but inside the esophagus. So the veins inside the esophagus, they dilate, they get weakened, they get kind of twisty, kind of like the varicose veins in the legs, which makes them prone to rupture. They're not as strong as they could be, so they're likely to burst, which is bad. So unfortunately with this disease, there are generally not very many symptoms. You don't really know you have it until one ruptures, and then suddenly you have all this blood bleeding out, and then you're like, oh, okay, now I know that I have an esophageal varice. What causes these is excessive alcohol intake. What happens is that when someone drinks a lot of alcohol, it's damaging to the liver, okay? And the liver, they share venous circulation. So let's see if I can show you in this picture. It's a complicated network, but basically you can see the liver shares the portal vein, that big one right here, and you can see that it goes from the liver and it goes up into the esophagus. So see that one vein here that goes up into the esophagus there? So if this vein gets blocked up because the liver is swollen or diseased or just not functioning well, and so the blood flow can't get through it very well because the liver is damaged, then all the blood's gonna back up into the esophagus. Does that make sense? So then the vessels inside the esophagus are gonna get dilated and damaged, and they're likely to bleed. And like I said, that's from excessive alcohol, which causes cirrhosis of the liver. That's what, and that condition where the blood flow is backing up is called portal hypertension. How we diagnose this is the same way as with an endoscopy. They put a camera down and see if they can see any of those varices inside the esophagus. Treatment, it kind of depends on the stage of the problem. So if they've lost a lot of blood, obviously giving them some blood to replace it. There are 2 other procedures called sclerotherapy and ligation, which are also similar for what they do for the varicose veins in the legs. The sclerotherapy is where they inject like a medication that kind of like stiffens and hardens those veins to kind of like keep them from rupturing, in a sense. And then ligation is where they tie them off to keep them from bleeding. So it kind of just kills the vein by putting a band around them to keep them, it's basically to kill them off so they don't rupture in the future. And here's a picture of the esophagus, of those twisty veins inside. You can kind of see like the S shape twisting like that. That is an esophageal varice. They shouldn't be shaped like that. They shouldn't be bulging out. They should just be like, in line with the rest of the skin, and they should be straight, not bulging out and crooked like that. Okay, esophagitis. Itis means what? Inflammation. So it's basically just an inflamed esophagus. Okay, so a symptom of this is heartburn. So heartburn, like I said, is a symptom, right? It's just where you feel that burning sensation. It's usually caused from acid reflux, but it can be from other things. In this case, just the inflamed esophagus is giving that burning feeling. Usually the pain is worse after eating or drinking, just because like the act of having something go down the esophagus is painful when it's inflamed. Okay. Usually the cause of esophagitis is GERD. So that constant acid coming up the throat causes it to be inflamed. Does that make sense? So it can also be as a result from someone having a suicide attempt. So if someone drinking bleach, for example, that's a common thing that people see. That's a cause of esophagitis. That harmful chemical like burns the throat, causes it to be inflamed and irritated. Someone with chronic esophagitis, especially if they kind of fit the profile, could indicate maybe they have a bulimic disorder where they're constantly making themselves throw up and have the stomach acid constantly coming up their throat. Does that make sense? So it's not always GERD where it's the problem with the lower esophageal sphincter. It could be a suicide attempt, it could be bulimia, it could be other things, but these are kind of the common ones. Again, diagnosis with endoscopy, looking down the throat, seeing the inflammation and the irritation of those cells. Treatment, antacids are a good one. The antacids work by neutralizing the stomach acid so that when the reflux does come up, it doesn't burn the cells the way it would normally. And again, also PPIs and H2 blockers, which again work by decreasing the amount of stomach acid that your stomach produces in the first place. Any questions on that one? No? Okay. Okay, next we have gastric and duodenal ulcers. So when you see the word gastric, it's just referring to the stomach. So these are stomach ulcers or ulcers in the duodenum. An ulcer is a wound or like a lesion or an area that's kind of been like, eroded through the tissue, a deep sore, so to speak. These can be very superficial or they can be very deep, even going all the way through perforating the entire organ, which would cause even more complications. So symptoms are a little bit different with stomach and duodenal ulcers, but there's some overlap. So with a stomach ulcer, it includes epigastric pain. So here's that term, epigastric. That's, if we go back to here, you can see the epigastric pain is that upper middle, which is where the stomach is. So that makes sense as to why the pain is there. Dyspepsia. Anybody know what dyspepsia is? It's a med term. Dyspepsia is indigestion. So like just the feeling of, fullness, bloating, not being able to digest properly. You might have a sensation of dull or gnawing pain that might feel like hunger pain, just kind of like that hollow burning pain, similar to when you're hungry. When you eat, that actually makes the pain worse. And this is because anytime that you eat food, your stomach responds by secreting more stomach acid to help digest that food, right? That makes sense? So if you have an ulcer in your stomach and you eat food and you start secreting more stomach acid, that stomach acid is going to burn that ulcer even worse. So that's why eating makes the pain worse. With a duodenal ulcer, similar, you also have some pain, maybe with some nausea and vomiting. You might see them clutching their stomach. But the difference with this one is that eating actually helps to relieve the pain, whereas with a stomach ulcer, eating makes the pain worse. Okay. What causes these ulcers? There are two major causes, although there are more. The main two is long-term use of NSAIDs. NSAIDs are a drug class. They stand for non-steroidal, so not a corticosteroid, okay? Non-steroidal anti-inflammatory drugs. So corticosteroids work by reducing inflammation, right? NSAIDs also work by reducing inflammation, but they're non-steroidal, so that means they just work in a different way. An example of an NSAID is ibuprofen. It's an anti-inflammatory, but it's not a steroid, okay? So taking those long-term, especially older people, they pop ibuprofen like candy. They are very common to have stomach ulcers. And then also H. pylori is a bacteria that causes an infection in the stomach and is a huge cause of ulcers, and it's the most common worldwide. It's a very common bacterial infection that causes these ulcers. Diagnosis, again, a lot of these are going to be endoscopy. Okay, so putting a camera down to see what's going on. That's like the main way that most GI disorders get diagnosed, either going through the mouth or going up through the anus. So like depending on where you're trying to go, which is the fastest route, right? If you're trying to go into the stomach, going through the mouth is quicker. If you're trying to look at the colon, going through the anus is quicker, okay? You can also do an analysis of the stomach contents. So like they can, go down there, take some of the stomach acid out. They can measure, see if there's any blood in there. They can look at the pH. They can see if there's any hidden blood, which is called occult blood, just to see like how bad the ulcer is. Treatment, if it is an H. pylori infection, then you get antibiotics to get rid of that bacteria. And then also again, PPI and H2 blockers, because the stomach acid is hurting the ulcer even worse. They might also hear them referred to as peptic ulcers. They kind of use that word interchangeably in the textbook, gastric or peptic ulcers. Here's kind of like what a peptic ulcer might look like in the stomach, causing some bleeding, versus one in the duodenum as well. Here's an actual picture of an endoscope looking at an ulcer in the stomach. It's kind of a bad picture, but most endoscopes going into the stomach are going to have super HD pictures because it's dark in there. But you can see that that's a big wound. All right, now gastritis. So this is going to be inflammation of the stomach, because gastro has to do with the stomach. So in this case, the stomach lining is inflamed. Symptoms of this also is going to be epigastric pain, because that is where the stomach is located. Feelings of indigestion, some belching, feeling of fullness, also a fatty food intolerance, just because breaking down fatty foods is more difficult, requires more work, more stomach acid to digest. What's causing this gastritis? Various things. Smoking can irritate the stomach. Alcohol can irritate the stomach. Spicy foods is also a big one. Use of NSAIDs. Again, so NSAIDs and H. pylori can cause ulcers, and they also can cause gastritis. So people who have stomach aches, after taking ibuprofen, be careful, because that might indicate developing an ulcer or some gastritis. H. pylori, again, the bacteria. Also, interestingly, I don't know if you guys remember about pernicious anemia we talked about in the immune chapter, the autoimmune disease, pernicious anemia, where the antibodies are attacking the parietal cells, which are the cells of the stomach that's secreted intrinsic factor, which absorb the B12, right? So people with pernicious anemia, they have antibodies attacking the cells of their stomach, which affects their B12 absorption, right? Those antibodies attacking tend to also cause gastritis, because it's inflammation from an immune response. Does that make sense? So it's autoimmune that causes this inflammation of the stomach. Diagnosis, again, using a scope to visualize it. You can also, again, analyze the gastric contents, do a tissue biopsy just to make sure it's not like cancer or something. Again, treatment, most of the diagnosis and treatments are going to be very similar with GI. Antacids, PPIs, H2 blockers. All right, gastric cancer. With any cancer, not just gastric cancer, weight loss is always a symptom. Not really sure why exactly, but weight loss is always a symptom of cancer. Persistent abdominal pain, nausea, dysphagia, which is difficulty with eating, melena, and anorexia. Again, anorexia just means lack of interest in eating, not the psychological anorexia. And then melena is like the blood in the stool. Causes of gastric cancer, interestingly enough, Japan has the highest incidences of gastric cancer in the world. Not really sure why, but they just do. So they have all sorts of screenings done in Japan but they don't necessarily do here. H. pylori is a big risk factor for gastric cancer. So if people have ulcers or gastritis related to H. pylori and they just don't address it, they don't treat it, the issue is that it can lead to gastric cancer. The Barrett esophagus is what they call a precancerous condition. So with constant reflux of stomach acid into the esophagus, it permanently damages the cells in the esophagus where they change. It's kind of like they adapt and they change structure to adapt to the constant flow of stomach acid being barraged at them all the time. So once that cellular change occurs, it's now a precancerous condition, and they call that the Barrett esophagus. Also, some other risk factors: high sodium diet and smoking. Again, diagnosis is going to be an endoscope, a biopsy. A biopsy is always going to be a diagnostic for any type of cancer, just to make sure that the cells are cancerous and not benign. A CT scan is always going to be useful to see if there are metastases. Okay, so CT scans for any cancer can always pick up if there's metastases anywhere. And then the TNM staging, if we remember that from chapter 1, the tumor node metastases. So based on how big the tumor is, if it has spread to the lymph nodes or not, and if there's metastases or not, is how they stage 1, 2, 3, 4 level of cancer. Treatment, they can do a gastric resection. A resection is basically a removal. So they can actually remove part of the cancerous stomach and then just kind of stitch it together to make it a smaller stomach. They actually do this also for patients that want to lose weight. They call it a gastric bypass. Or a gastric sleeve. They'll cut the stomach and make it smaller so that you'll eat less because you feel full quicker. So it's something that's a common thing. You can still survive with part of a stomach. They can even remove the entire stomach if they have to and just have the esophagus go straight into the small intestine. Obviously, it just makes it harder you can't eat big meals. You have to kind of just graze and eat smaller meals because there's not this big reservoir to store all that food. You kind of just eat slowly, but it is possible to live without a stomach.
What is it called when you remove the entire stomach?
Just a total gastrectomy. So this says here's or gastric resection is just taking part of it, they're resecting it, so they're taking part of it out and resecting it together, or just a total removal is just a total gastrectomy. And then obviously chemotherapy and radiation, always a part of treatment for cancer as well. Here's a picture of what Barrett esophagus looks like. You can see these weird blotchy kind of discolorations. It's not supposed to look like that. It's supposed to look all the same. So this kind of is an indicator of they have the precancerous condition for Barrett's esophagus. All right, appendicitis. Pretty common. Anybody ever had their appendix removed? Just curious. You have?
Yeah.
How old were you when that happened?
16.
Really? What did it come on suddenly, or was it kind of a slow gradual?
It was probably gradual. But they let me go. I had endometriosis, so I had to have surgery for that, and that's when they found it.
They just did it at the same time?
Yeah.
Okay.
It was tethered. It was all in different pieces.
Yeah. So it's a super common thing. We don't really know what the purpose of the appendix is. It's kind of just nobody has any idea what the purpose of it is. So removing it doesn't affect anything. It's not like removing like the liver, which you can't live without. Here's a picture of where the appendix is. It's right at the base of that large intestine there. That's actually, that part is the beginning of the large intestine, so the small intestine connects there, and then the anus is the end of the large intestine. So looking at its location, you can see why the pain would be located in this spot, because that's just where the appendix is. Okay, so appendicitis can be a medical emergency depending on how inflamed it is, because it has the potential to rupture if it gets too inflamed. Some symptoms are pain in the right lower quadrant. That's what RLQ is. Very common to have these acronyms for the abdomen, RLQ, right lower quadrant. They also call that spot the McBurney's point right here, because it's kind of a classic hallmark sign of appendicitis, because that's the only thing that's really there that would be inflamed in that way. Nausea, vomiting, fever, diarrhea, just general intestinal upset. What's causing this is that the appendix can become blocked with some kind of blockage. Usually it's hardened feces, so people who get constipated a lot, like the feces can get blocked in there, and then it just causes it to swell and the bacteria grows and gets inflamed. So you can see here is a picture. That little squiggly tail is the appendix. So a piece of fecal matter, it's not always fecal matter, but that's the most common reason, kind of gets stuck in there, which causes it to swell and get bacteria overgrowth. Diagnosis, you can do imaging. Most of it's just based on signs and symptoms though. Someone comes in with like very tender pain right there, and they have an increased white blood cell count, maybe fever. They can do imaging to see that it is inflamed, like a X-ray or CT. And then treatment, they just usually take it out, just because like you don't really need your appendix for anything, and there's no point in trying to spare the organ. They just remove it, an appendectomy, and then giving some antibiotics to just address the bacterial infection. Any questions about appendicitis? All right, now we're going to talk about two different types of hernias. The first one is hiatal hernia. Hiatal hernia is where there is a defect or a weakening of the diaphragm, and then a piece of the stomach like slides through where it shouldn't be. So let me show you a picture here. Your diaphragm kind of encompasses the stomach, and the esophagus kind of goes through it. So if there's a weakening of the diaphragm, part of the stomach can come up through it and kind of get, it's kind of like this, I don't know, this weird bulge where it shouldn't be. So here's another kind of picture of what's happening. So it kind of like slides up and gets stuck and trapped. So when that happens, similar symptoms, heartburn, it's feeling of like some pain there just because it's messed up, it isn't located where it should be. Swallowing can be difficult just because the stomach has gone up to where the esophagus is. Maybe even some respiratory complications if like you're having a hard time breathing, right? Because the diaphragm is what controls respiratory, right? So if like you have this lump of stomach in the way of the diaphragm, it can make it harder to breathe. Talked about the etiology. Diagnosis, again, endoscopy. They can see that it's shifted locations. Treatment, they try to do, diet modifications to kind of like make it less work on the stomach. Sometimes it fixes itself, sometimes it'll go back, or sometimes you just manage the symptoms and it doesn't bother you. If that doesn't work, then they can do surgery to fix it, but generally surgery is like a last resort because it's just more complicated. So if you can deal with the symptoms by just changing your diet, taking some antacids, sometimes it'll fix itself, that's preferable, but they can do surgery. Any questions about this one? All right, the next type of hernia is called an abdominal hernia. This is where there's a weakening of the muscular wall of the abdomen. So you can kind of see it, like there's a little bulge that's visible. What happens is here you can see like that yellow stuff is fatty layer, but this dark, I don't know if you can really see it from where you are, but like this dark red layer is the muscle, and there's a weakening in it, so the bowel protrudes through the muscular layer and comes out into like this bulge that can be visible. So obviously symptoms is that you notice a bump or a bulge. So, and then if you poke it, sometimes it can move back inside. Also with males, they often can have sharp pain in the scrotum because the bowel can actually go down into the testicles. So here's a picture. If there's a weakening in the lower abdomen, like the bowel can slip down and go into the testicle, which is why like when males go in for primary care checks and they do the squeeze and cough, that's what they're checking for, to see if they can feel any bowel. I know none of you guys have had that because you're all women, but it's a common thing that they screen for in males. This can happen just if someone's just not very muscular, if they're just kind of weak in general, their abdominal muscles might not be that strong. The core strength is important. A lot of times though, it can be from trauma, from heavy lifting. A lot of dudes, do heavy lifting, but they don't have good form, and they can tear different parts of their abdomen, or they're trying to lift more than their body is actually ready for, so it can cause that. Even pregnancy can split the abdominal muscles. I think it's called diastasis recti, where the abdomen kind of separates. I don't know if anybody ever heard of that. Like there comes like a space in between the abdomen, and then your bowel can poke through that way. So that's what it is. Diagnosis is pretty easy. Generally, you can see it. It's visible. If you hold a stethoscope up to the bulge, you can sometimes hear bowel sounds, like the digestive sounds coming from that spot, where normally, like, you shouldn't. You should just hear, because it's over the muscle, you shouldn't hear it there. And then imaging as well, so some kind of X-ray or CT. As far as treatment, you can try to wear this brace, which is called a truss. Basically just puts pressure on it and try to push it back inside where it's supposed to go. If it's like a simple hernia, if it's more involved or more complex and that doesn't work, you can just do surgery to have it go back through and fixed. Are any questions about the difference between those two, abdominal and hiatal? Basically both is just a weakening and something protruding where it shouldn't be. All right, now Crohn's disease. Crohn's disease is a chronic inflammatory condition of the GI tract. Okay, so the whole, not just like the stomach, but the entire GI tract. So you'll have like chronic diarrhea, constant cramping, abdominal pain in that right lower quadrant generally is the most common. Weight loss is a big one. Malaise, just that feeling unwell and tired. Nausea, anorexia, fever, all these different things, your typical GI issues. What's happening here is that all of the layers of the entire GI tract, from the mouth all the way to the anus, are potentially inflamed. Okay, so there's edema, which is the extra fluid, and the cause of this is unknown. No one really understands why this happens. There is a suspicious that it's autoimmune related or allergy related, either like some strange allergy that we don't know about yet. We know about gluten intolerance now, what we didn't know about that, several years ago. So there could be some new allergen that's causing it, or an autoimmune cause. Diagnosis, again, same thing, is going to be either a colonoscopy going in from the anus or an endoscopy going from the mouth. Just kind of look around and see where the areas of inflammation are, to see if it's caused by something else. Like is there cancer involved? Is there a hernia somewhere, or like what's causing it? Unfortunately, the treatment is incurable since we don't really know what's causing it. We can't really treat it. The goal of treatment is to just control the flare-ups and just try to keep people in remission. So avoiding triggers. People can be like, oh, every time I have coffee, it makes it worse. So avoid coffee, or avoid smoking, avoid alcohol, spicy food, typical things that trigger these sorts of things. You can do antibiotics if there's some kind of bacterial problem. Corticosteroids are going to be the big one though, because that helps with autoimmune and inflammation, right? So corticosteroids are a big one. And then since the pain can get really bad, narcotics are often given just to kind of control the pain. So it's like, hard, heavy duty pain pills to help control that pain there. And here's kind of just a little visual, like there's just the dark red areas are areas of inflammation. So it can show up and pop up anywhere. It's not just like the inflammation happens in one spot. It can change. It can be in the mouth, it can be in the stomach, it can be in the large intestine. It's just kind of all over the place. All right, now ulcerative colitis is very similar to Crohn's disease. except of the location of the inflammation. So with Crohn's disease, it's kind of all over, but with ulcerative colitis, it is specifically just the colon. That's why it's colitis. It's inflammation of the colon, right? So you're not going to have inflammation in the mouth or in the stomach. It's just the colon and the rectum. They're all connected. Okay, so symptoms of this is going to be bloody and mucousy diarrhea, which makes sense because the colon here is where the last passage through before the stool comes out. So with a lot of inflammation and ulcers potentially, that's what the ulcerative means, is that it could be inflamed and the presence of ulcers in that colon. So bloody diarrhea, mucousy diarrhea, severe cramping, having an urgency to defecate, which is like you just feel like you have to go right now, and frequent stools, or having upwards of like 10 to 20 times having to have a bowel movement a day, which is that's a lot, and that's very inconvenient, causes some problems with daily life. No one really knows the cause of this. The same thing with Crohn's disease is that we think it's probably some autoimmune cause or some kind of allergy related. Diagnostics is going to be the similar, doing a stool analysis, so looking at that bloody mucousy diarrhea, looking to see how much blood is in there, are there any bacteria, like what's going on with it. Looking at a CBC, so a CBC is a specific lab test that's a complete blood count. So it'll tell you the white blood cells and the red blood cells. So if there's been a lot of bleeding in that diarrhea, your red blood cell count is going to be lower, right? Because you're bleeding out. And a colonoscopy. So an endoscopy wouldn't be useful in this case because the inflammation's in the colon, right? So why go through the mouth, go all the way down? We can just go from the back end, right? So the colonoscopy is going to be the visualization of choice. And the treatment, again, is very similar to Crohn's disease, kind of just controlling the flare-ups. So corticosteroids being the big one. The issue with corticosteroids is that, like, with diseases like this, is that it's kind of a lifelong condition. They typically only use corticosteroids in the middle of a flare-up. They don't want to be on corticosteroids all the time because it lowers your immune system. So being on corticosteroids long-term can make you prone to get infections, right? So you can't just take corticosteroids all the time. You can just really reserve those for when you're having a severe flare-up. Anti-diarrheal drugs, obviously they're having 10 to 20 bouts of diarrhea a day. So anti-diarrheal drugs are going to be really helpful with their quality of life to help reduce the amount of times they have to have diarrhea. And then if it's just really bad and nothing's working, they can also just remove that part of the colon. So that's called a colectomy. If they remove this entire bit that's inflamed, what they do, so here's a kind of a picture, they cut off that piece, and then that spot here where they cut it off, and it ends up, they do what's called an ostomy. So they have it actually come out of the abdomen instead of, because there's not enough to reach all the way to the anus. You cut the piece off, so there's not enough to go around. So they'll put an opening into the abdomen to have, basically this is your new rectum, essentially. And it's pretty common, actually. A lot of people have these, but they're called a colostomy bag. So the feces come out into this bag collector, and people have to change it out. The plus side is that you never have to make time to go to the bathroom because you can just change it whenever you need to. It's kind of like a diaper sticker in a sense is what it is. I've seen a lot of them. They're not always permanent. Sometimes they can be temporary, and then they can. So sometimes they can reattach things later if they leave it inside you. If they remove it completely and take it out of the body, then it's permanent. But sometimes they can actually reattach it later, and so they're not always permanent. Sometimes they can be temporary. To just give your body a chance to heal sometimes. Okay, any questions about the difference between ulcerative colitis or Crohn's disease? They're very similar. The main difference is just the location, essentially. All right, let's talk about intestinal obstructions. A second. Okay. Intestinal obstructions is kind of self-explanatory. It's just something's obstructing the intestines. Right, so this can be lots of things. It can be a foreign object that someone swallowed. It can be very hard feces, very constipated. Various things can cause an obstruction. With cats, a lot of the times it's hair. Hair balls cause obstructions in cats. So basically, whatever's inside the intestines can't move forward because there's something blocking it. This can cause severe pain, obviously. Everything's backing up and it can't come out. Sometimes it can back up all the way into the stomach and then you just start vomiting out because you can't pass the other way. So that can be very unpleasant. Very bloated and painful abdomen. Like I said, there can be lots of various different reasons this is happening. A neoplasm, and what's a neoplasm? It's a cancerous tumor, right? So there could be a tumor that started growing in the intestines and then the big tumor is now blocking the exit, right? So that could be a problem. Fecal impaction is just severe constipation. You're just backed up with a lot of feces. A volvulus or an intussusception, I'll show you a picture of that in a second. Or a strangulated hernia. So let's go back to look at the picture of the abdominal hernia. So, right, if this gets pinched really hard, like, then it can't progress through. Does that make sense? Like, if they pinch a piece of it, then the stool can't go all the way through. So that's called a strangulated hernia, where it's pinched off. Sometimes there's not any problem, that it's not pinching very hard, but sometimes it does. Let's go back. Okay, or paralytic ileus. A paralytic ileus basically is there's not actually a physical blockage. It's just that the intestines themselves have just kind of shut down, like they've stopped working for a bit. And this is very common after surgery. So if anyone's like been under anesthesia, a paralytic ileus is very common, and that's usually why they tell people to just, take it easy with eating after surgery, to not eat a huge meal, to kind of like go on like soft diet or liquid diet, because your intestines have kind of shut down and they're the last thing to wake up after surgery. So they usually just kind of like, it might take a couple days for your intestines to wake up and then again start working and flushing things out. So it's not a blockage, so to speak. It's just that the intestines have just taken a break. Sometimes that can also happen from some narcotics, like opioids can cause problems with the paralytic ileus as well. Let me show you a picture of the volvulus and the intussusception. So this is a volvulus. It's basically where the intestines get all swirled up and tangled on each other. They just twist around each other and start blocking off the blood circulation. This is kind of like one of those weird things that happens, no one really understands why. Pregnancy often can cause this just because things are getting moved around a lot, and so things can get tangled and twisted. Here's another picture of what a volvulus looks like, where just like the intestine is twisting around itself and blocking off the blood circulation. And then an intussusception is where like a piece of the bowel like collapses inside of itself, so it like telescopes back inside of itself. Like those telescopes that like you pull it out and then it like goes back inside. It's basically what your intestine is doing on it to itself. That's an intussusception. Okay. Diagnosis is just going to be visualization. So an x-ray will show you if there's an object blocking it or if there's some kind of twisting going on. Treatment, depending on what it is, surgery can be an option, especially if it's like a volvulus. You're going to have to go in there and manually untwist it. Possible resection means removal. So like, for example, if this whole bit died because the blood supply was blocked off for so long and like the tissue got necrotic and you can't save it, you have to go in there and take it out. And then again, possible ostomy. So depending on, like, let's say this whole chunk got taken out, they might have to have a temporary ostomy until they can reconnect it to a place of healthy bowel. Does that make sense? So they have to take out the old stuff, give you a temporary ostomy, and then come back in later when everything's kind of calmed down and then reconnect to two different spots so that it can be one continuous unit again. Okay, any questions about that one? Okay, so diverticulitis, again, itis means inflammation, so inflammation of a diverticula. A diverticula is a little polyp or like little outpouching of the colon. So here's like a little picture of what a diverticula looks like, those little bulgy sacs that are coming out. So what causes these, again, is a weakening of the colon. So like for some reason the wall lining of the colon has gotten weakened so that these little blips pop out. It's kind of like an aneurysm with in the cardiovascular chapter where the weakening of the arterial walls causes the bulgings. It's the same idea. So symptoms of this is going to be acute abdominal pain, fever, it's an infection. Pain usually is going to be in the left lower abdominal area. So left lower is down here because that's where your colon is. So these diverticula are on the colon, okay, right before the passage out of the body. Constipation can happen, or loose stools. So depending on the person, can be nausea and vomiting as well. So what happens with these is that, like I said, weak areas in the intestinal wall start making these diverticula. That condition itself is called diverticulosis. So just the presence of the diverticula is called diverticulosis. So on the left you can see that, and then on the right, once they become inflamed and potentially rupture, that's called diverticulitis. So an inflammation of the diverticula. Diagnosis is going to be with a colonoscopy. Go up there and look at it. Also, a barium enema can be helpful. You'll see that in the textbook. A barium enema is basically where they stick up a tube and they release like this liquid, which is called the barium substance. And basically what it does is it's like it coats the lining of the intestines and takes a picture when they do a CT to image it better, so that they're able to see, like, if the liquid goes into the little outpouchings, they can see where all the little diverticula are. Does that make sense? Let me see if I think I have a picture. So here's a picture of like the barium enema that's collected in the various diverticula, and that's the white stuff. So they're able to just see where all of them are. Does that make sense? Here's a picture of what an actual diverticula looks like in an actual colon. Treatment for these, high fiber diet, because a lot of the times the diverticula are caused by poor eating habits. So high fiber is a good one. A lot of the times the weakening of the intestinal wall is related to constant constipation. So like people who are constantly constipated and straining, like that weakens the wall of the colon from that constant pressure and straining. So having high fiber will help people not be constipated. Exercise also gets the bowels moving better. Antibiotics are useful once it's gotten to the point of diverticulitis, because the itis is the inflammation related to bacteria getting trapped in there. So fecal matter can get trapped inside those little outpouchings, and if they get stuck in there, they can start brewing bacteria and cause the inflammation. Possibly surgery. They can do kind of the same thing where they do the ligations, they tie them off, which basically gets rid of them, to get rid of those diverticulas. We want to avoid rupture, because if they rupture, now you're having fecal matter going into the abdominal cavity, which is very bad. Any questions about this one? Just stop me if you do. All right, this one, pseudomembranous enterocolitis. I actually have never heard it called this. I've always just heard it called C. diff. I don't know if anybody's ever if anyone's a CNA or worked in the hospital or whatever. Everyone knows C. diff. Okay, it's like once you've encountered C. diff, you'll never forget it. It is a bacteria that causes severe diarrhea. Like the diarrhea is so bad that it's just kind of constantly coming out of you. It's not like you have 10 to 20 episodes. It's like you just constantly are going. And it's really bad. It causes very green, foul-smelling, basically watery diarrhea. It's literally just pouring out of you like water. Severe fever, weakness and cramping. A lot of that weakness is because you're just super dehydrated, because you're just losing tons of water all the time. So dehydration is a big issue, why a lot of people go to the hospital. Anal irritation, just because when you have a runny nose and you're constantly blowing your nose and your nose gets irritated, well, imagine out the other end, you're constantly going all the time, the anus is going to get irritated. Obviously, in incontinence, they just can't hold it. It's just constantly coming out of them. When I was a nurse in the hospital taking care of patients with C. diff, you never forget the smell of it. You can identify it from a mile away, be like, that's a C. diff. Yeah, it has a very distinctive smell. But I just never heard it referred to as the official name of pseudomembranous enterocolitis. Everyone calls it C. diff. Anyways, C. diff stands for Clostridium difficile. That's the name of the bacteria that's causing it. How do people get this? Basically what happens is this can happen when people take long-term broad spectrum antibiotics. So broad spectrum means that there are different types of antibiotics. There's narrow spectrum and there's broad spectrum. So narrow spectrum means that they're like targeting very specific types of bacteria, and they're only going to kill that particular kind. There's a gazillion different types of antibiotics, there's a gazillion different types of bacteria. Okay, so a narrow spectrum is going to target very specific ones, whereas broad spectrum are going to kill off most bacteria, good bacteria and bad bacteria. I know people tend to think that all bacteria is bad, but there's actually like very healthy and good bacteria that you want to have, especially in your gut. So you've heard of probiotics? People take those for gut health. Probiotics just means good bacteria. So you're taking good bacteria into your gut, which helps with being regular, helps with constipation, because the good bacteria release various enzymes and things that helps keep your gut healthy. So when people take broad spectrum antibiotics, it kills off everything. It kills off the bad bacteria, but also kills off all of the good bacteria that's in your gut, which basically makes your gut vulnerable and empty to be taken over by really bad bacteria. So it's kind of like, I kind of like to think of it as like hotel rooms. Like if all the hotel rooms are occupied with good bacteria, there's no room for bad bacteria to move in because there's no occupancy. But if all the good bacteria is gone and now it's just empty, the bad bacteria, the Clostridium difficile, is like, oh sweet, we can move in. So they move in, they take up residence, and now you're overrun with the bad bacteria. Does that make sense? So the Clostridium difficile will release all of these harmful toxins, which is very destructive to the bowel tissue, causing all of this diarrhea. It's very contagious. So like if someone has this, it's spread by contact. So you have in the hospital, they would have to like gown up and all this protective gowns and gear to like prevent spread, because it can be very easily spread to someone else just by contact. So if you come in contact with any of the diarrhea, you gotta wash your hands with soap and water. Diagnosis is really easy. You just do a stool culture. So you take a stool sample and they say, oh, yep, there's C. diff in here. The treatment is, so there are varying levels of antibiotics. So if someone has this because of them taking the broad spectrum antibiotics, immediately change antibiotics and get one specifically that kills the C. diff off, right? Specifically, the book talks about vancomycin. Vancomycin is like one of the strongest, toughest antibiotics that we have. It's very, very commonly used for like extremely severe bacterial infections. It's pulling out the big guns. So vancomycin is kind of like the last resort antibiotic to kill off something if someone has an infection. Lots of fluids is also really important. Number one, just because they're super dehydrated. But number two, also it helps flush out those toxins. Like I said, the Clostridium difficile bacteria are releasing these harmful toxins, which is causing the bacteria. So continuing to take more and more fluids will just help keep flushing them out. Taking an anti-diarrheal is going to be off limits for these people, even though they desperately want it. Just because if they take anti-diarrheals, it's going to prevent them from flushing out those toxins, right? You want to keep flushing it out because it'll help them get better quicker. Does that make sense? So anti-diarrheals are useful for like Crohn's disease. That's because it's not related to bacteria. It's just related to inflammation from unknown reasons. Does that make sense? This one is caused by bacteria, so we don't want the bacteria to stay in the colon. We want to get it out. Any questions about this one? We're good? Sorry, I can't see this half of the room, so I'm like over here. Don't feel shy if you have a question. This is what the gut looks like with pseudomembranous enterocolitis. This is what it looks like to be like your gut overgrown with the bad bacteria. Very bad. And that's what the name pseudomembranous means. Like this is what the pseudomembrane is that they're referring to. You can see all the pus and like the bloody stuff in the middle, like all this blood here. Very uncomfortable. All right, now irritable bowel syndrome. So, I mean, it's kind of self-explanatory in the name. Your bowels are just irritated. So you can have cramping, aching, just generic abdominal pain, but you feel better after defecating. It kind of makes you get rid of that bloating and uncomfortable feeling. People typically either have irritable bowel syndrome constipation or irritable bowel syndrome diarrhea. Typically one or the other. Sometimes people like go back and forth, but you might have seen commercials for like IBSD or IBSC, it's irritable bowel syndrome constipation or irritable bowel syndrome diarrhea. So the cause of this is also unknown. We don't know a lot, actually, in the medical field about the GI tract. Autoimmune is typically suspected. Also, again, allergens with the foods. There are triggers people find, like, oh, every time I eat this one thing, I get IBS. It happens to be more common in females, which tracks because, again, most autoimmune things are more common in females just because women are inherently harder on themselves, and that's literally what an autoimmune disease is. You're attacking yourself. Diagnosis. This is kind of interesting because there's no specific diagnosis that can diagnose irritable bowel syndrome. It's kind of just ruling out other things. So they'll be like, okay, well, it's not bacterial. We don't see any bacteria. It's not cancer. It's not this. It's not that. There's no diverticula. Like your white blood cell count is normal. Your red blood cell count is normal. So like there's nothing like showing up, but like yet the person's still having symptoms, if that makes sense. So they're like, well, we can't really find anything wrong with you other than it's probably just IBS. So that's kind of how they diagnose it. Treatment is really just, depending on what the issue is. So if you have diarrhea, then, having like the anti-diarrheals or high fiber to kind of help bulk things up a little bit. Stool softeners and laxatives can be helpful for those with IBS constipation to kind of just help things come out a little bit better. But yeah, it's really just treating your symptoms. There's not like a cure for it. All right, now we're going to be in peritonitis. Peritonitis is an inflammation of the peritoneum. So you guys remember we talked about pericarditis, which was inflammation of the lining surrounding the heart, right? So peritonitis is inflammation of the membrane or the lining around the stomach. So there actually wasn't a good picture that I could find, but most organs have a membrane surrounding it. So the brain had one that was meningitis, inflammation of that membrane. So peritonitis, there's a membrane surrounding the entire abdominal cavity, and if that gets inflamed, it's peritonitis. So this one is abdominal pain, nausea, vomiting, weakness, profuse sweating, fever because it's related to some kind of infection. The pain being just so bad that you don't want to move because pretty much every movement involves your core muscles in some way, and if that area is inflamed, it's going to be very, very painful. A very hard and rigid abdomen, so you can kind of see in this picture here how distended they are. This person's not pregnant. Okay, this is just the inflammation of their abdomen. Okay, so there's a bunch of fluid, like edema rushing to the area. The inflammation is making it this swollen. So it looks like this person's about ready to have twins, but they're not. This is just the peritonitis. Very painful, as you can probably imagine. So the cause of this is going to be some kind of bacteria getting into the abdominal cavity. Okay, so there are a lot of different things that can cause peritonitis. We've already talked about several things that are like inflamed and could rupture, right? The appendicitis, if the appendix ruptures and all that contents gets into the abdominal cavity, you can get peritonitis. If a diverticula or diverticulitis, if that ruptures and gets into the abdominal cavity, you can get peritonitis. If a stomach ulcer goes all the way through the stomach and like contents leak into the abdomen, you can get peritonitis. See what I'm saying? So there's lots of different things that can cause it. Basically, something is getting into the abdominal cavity that shouldn't be there. So it could be bacteria, it could be feces, it could be stomach acid, it could be, because someone was stabbed into the abdomen. There's like so many different causes of peritonitis. Diagnosis, obviously, there's going to be imaging done, and they can just see the inflammation. It's kind of hard to miss. There's obviously going to be a very high elevated white blood cell count because there's a huge infection. You're gearing up your white blood cells to fight back. Treatment, treating with broad spectrum antibiotics. So to try and kill off as much as you can. Antiemetics are just, throwing up. Emesis is throw up. Analgesics are painkillers because it's very painful. If it's bad enough, like if something has been perforated, like if the stomach has been perforated with an ulcer, or if there's been something that's ruptured, surgery is going to be required to stitch it back up so that there's no more leaking going on. Also, draining of the contents. So like all this fluid buildup here is going to have to be drained out. Okay, Any questions about this one? What can cause it or anything like that? Make sense? All right, hemorrhoids. Most people probably know what hemorrhoids are. It's kind of like the varicose veins that we talked about with the esophagus and in the legs, but now in the rectum. Okay, so dilated, weak, twisty veins coming out of the rectum. This can cause bleeding if they burst. So if someone wipes and they see bright red blood, that could be from a bursted hemorrhoid. Pain, obviously, especially if someone's constipated, it's very painful with the next to these veins. It can be very itchy, and sometimes you can even see them protruding out. There are internal hemorrhoids and there are external ones. So sometimes they can pop out of the anus, other times they're going to be like a little bit higher up in the rectum, so you can't see them. What causes this is kind of like the same thing that causes any weakening. So constant straining and constipation, putting pressure, weakening them. Pregnancy is a big one just because you've got a whole human inside of you putting pressure, and then also especially during delivery, all that straining and pushing can cause hemorrhoids. What else? Diagnosis is usually done by just a visual inspection, especially if they're external, you can see them. You're like, oh, yep, that's a hemorrhoid. Or you can just do a very superficial, colonoscopy. You don't even have to go in that far and you can see them. Treatment depends on, how bad it is. So if, it hurts only when you're constipated, they'll try to just change your diet so that you don't have the hard constipation, and they can sometimes heal themselves if given a chance to heal. Increasing your water intake and stool softeners. All of this will just help make it less painful to go when you have these. You can also do the same kind of thing for the varicose veins and the esophageal varices. The sclerotherapy injections, you inject that chemical into the veins to harden them up, or cryotherapy, which is freezing them off. And then ligations, where you just tie them off so that they don't have to rupture. They just kind of kill the vein in that sense. So here is a little picture of what they can do. They can tie a little band around them, which will kill them, and they'll eventually just fall off. That's an internal hemorrhoid, so you wouldn't be able to see it from the outside. All right, cirrhosis. I mentioned this one a little bit earlier when he talked about the esophageal varices and the portal hypertension and backing up. So cirrhosis basically is just a chronic destruction or scarring of the liver. And again, alcohol is the biggest cause of this, but there are other things that can cause it as well. So it's kind of one of those things where people assume that, oh, you have cirrhosis, you must be an alcoholic, or oh, you have lung cancer, you must be a smoker. Those are the most common, but there are other things. We just gotta be careful not to assume things about people. Symptoms of this with cirrhosis, kind of just a loss of appetite, losing weight, nausea, vomiting, and indigestion, sometimes abdominal distension and edema, so it can kind of look similar to a peritonitis situation. Also, a lot more easily bleeding and bruising with some jaundiced skin. Anybody know what jaundice is? Yeah, so we get the yellowing of the skin, sometimes even the eyes, the eyes can look yellow. Like I said, alcohol is the most common. Hepatitis is also another cause. So hepatitis is a viral infection of the liver, and if it's left untreated or if it gets bad enough, it can cause permanent destruction and damage to the liver. So you can have cirrhosis due to hepatitis and not have ever drank anything in your life. What's happening is that the damage to the liver damages those healthy cells, and they eventually just get replaced with hard scar tissue, and it doesn't work the same. You're cut yourself and got a scar, and the skin looks different than the surrounding skin, so it's the same thing. The scar tissue is replacing the healthy tissue, and then the liver just doesn't function anymore. Diagnosis, they can do palpation, so they're going to feel the liver. Some people are really good at feeling them. They're usually enlarged. They're bigger than normal. They are really hard and firm to the touch. The elevated liver enzymes, remember, these keep coming back. So AST and ALT are enzymes that the liver releases when it's in distress. Okay, so it's kind of like waving a flag, help me, I'm in distress. So those will be elevated in any time there's a liver disorder. So whether it be cirrhosis or hepatitis or anything going on with the liver, those enzymes will be elevated. Bilirubin levels will also be elevated, and you can just do imaging with CT and a biopsy. A biopsy will tell you if it's cancer or something else. With treatment, stopping alcohol is very important. Sometimes if it's bad enough, you can need a liver transplant. And then depending on how much edema and swelling and distension there is, a paracentesis can be used to drain that fluid out. So this also is a treatment for peritonitis as well. So you can see like all this swelling and fluid accumulating in the peritoneum, which is the area of the abdominal cavity. That's called ascites, when there's all this fluid accumulating in that abdomen, and it happens with cirrhosis and also peritonitis. So like all this distension, a lot of that is fluid. So a paracentesis is they're going to inject like a needle into that space and just kind of drain it out into a bag to get rid of that fluid buildup. This is a picture of a healthy liver and a liver with cirrhosis. So you can see that it looks very different, and the scar tissue prevents it from functioning. All right, any questions about those? Do you guys need a break? I've kind of just been, if you needed to go to the bathroom, you can, but we can take a short break if you guys need a second. Or would you rather keep going? You would take a short break? Like, how about like 5-minute break? Stretch your legs, go to the bathroom real quick. Oh, thank you so much. Either of you do anything exciting over spring break? No, just stay home.
Do you know for the study guides if like an answer key can be posted? Because I have that different version of the book and some of it just didn't.
Can you speak up a little bit? I can't hear you over the sound of the projector.
Do you know for the study guides if an answer key or something will be posted? Because I have a different version of the book.
Oh, yeah.
So some of it, I don't want to like send you like 15 questions and be like, "Write an answer for them."
What version do you have?
So when I got the list from like the chat library, it said the 8th edition.
So you have the 8th.
Yeah, but
Okay.
a lot of it, like the little small details won't line up.
Yeah. Well, I don't have. How about you just let me know? Just as you're working through it. I usually answer right away. If you have something you can't find, I'll just let you know what it is. I can just open the book and look and tell you. But yeah, I'm sorry about that. I mean, most of the information should be similar. If you can't find something, I'll just tell you what it is. I don't want you to have to suffer because of that. I just don't post the answers because then people are just going to copy the answers and not do the work. You see what I'm saying? The whole point of the study guide is to get people into the book to read it, right? Because if I just make a study guide, I've noticed that people don't actually read the chapters. So this way people have to like look at the book and see if they understand. But like for you, since you have a different book, just email me if you can't find something. It's weird seeing you guys so later in the afternoon. Like I'm used to seeing you guys all sleepy and tired before the caffeine hits. But Miss Squire said she needed an extra hour, so
which I was not sad about because I'm not a morning person. So I was like, if you want to teach in the morning, that's great. That works for me. But that does mean we have one less hour to work with. So try to go faster. Which I think unfortunately means we might not have time to do the Jeopardies all the time, which is sad. But we'll try. I'll still make them though, and you can do them for yourself if you want to practice them at home. Some people say they really like them and it helps them a lot. Other people might not care, but if it helps you guys, it's worth it. Is it helpful to you? Yeah. I had several people say that it helped them just kind of practice in preparation for a test. You want to come learn about hepatitis, Miss Kelly?
Okay. This may be too scintillating for me.
Done for the day? You done for the day?
No.
Wishful thinking?
I gotta go submit a work order.
Oh yeah. Well, thank God this one's working, because I don't know, we would have just stared at each other, so.
Well, the one in 2104 is working too, so it's just mine.
Oh, that's weird.
It's fine.
All right, we're actually almost through this one, so that's only got a few slides left. All right, so hepatitis. Itis means what? And hep refers to which organ? So inflammation of the liver, okay? So this is caused from a virus. There are several different viruses. We got hepatitis A, B, C, D, and E. We're only gonna talk about hepatitis A, B, and C because those are the most common ones in the US and the only ones that are going over in the book. So they can be very mild all the way to very severe, causing liver destruction. We just talked about cirrhosis. So cirrhosis can be caused by a hepatitis infection that goes without treatment. So various symptoms of hepatitis include headache, anorexia, again, just the loss of the desire to eat, malaise, just a general unwell feeling, fever, because you're fighting some kind of infection, nausea, dark urine, clay-colored stools is one of the different symptoms for this. Usually a lot of the GI symptoms are very similar, like nausea, vomiting, bloating, diarrhea. They're kind of all the same. Clay-colored stools is one of the differences. So when you see that, you'll know that, okay, this is one that's different from the other ones. It kind of clue you in that it's going to be hepatitis. Jaundice is another one. Jaundice is a symptom of hepatitis and cirrhosis both, because it's both related to the liver. Okay, so the liver, its job is to filter out the toxins in the bloodstream, right? And when the liver can't do its job, the toxins build up, causing yellowing of the skin. So all those toxins are leaking into the skin, into the eyeballs, the sclera. Also, the liver gets enlarged, so it's inflamed, it's growing, it's swelling. How do we diagnose this? Well, you can do a blood sample, and then when you do that blood sample, you'll see the presence of antibodies and antigens. Remember what antigens are from the immune chapter way back 2 tests ago? What are antigens? You don't, Kelly's shaking her head. An antigen is a marker that's on a bacteria or a virus. So remember, every cell has antigens. It's kind of like your team jerseys to identify which team you're on. Are you part of the host cell, or are you a foreign invader, right? Let's say my antigens are all team red. Okay, so, and then a bacteria comes in and they have different antigens. They're green, so I know that that's the enemy, so we fight them. Does that ring a bell? Yes? Nods? Okay, so those are antigens. So you'll see antigens for the hepatitis virus, okay, in the blood sample. You'll also see antibodies formed against those, okay? So like, okay, you have the presence of hepatitis A antibodies. Well, that means that you've been exposed to hepatitis A because your body has made the antibodies for it, which means you have hepatitis A, okay? AST and ALT, what are those? Good, liver enzymes that are released when the liver is in distress, okay? So for treatment-wise, we're going to give them antivirals, not antibiotics, because it's a viral infection. Antibiotics do not work against viruses, okay? Immunoglobulins are also an option. I don't know if you guys remember this or not from the immune chapter, but there were different ways of getting immunity. There was vaccines, which is, a sort of passive immunity. There was also the administration of immune globulins, which is where you basically give someone antibodies. Like someone else made the antibodies, and you're giving it to them so that because maybe they just can't make antibodies that well. Okay, so you're giving someone else antibodies to help fight the infection. That's passive immunity. Okay. All right, so let's talk about the difference between hepatitis A, B, and C. Hepatitis A, highly contagious. This one's very common to have breakouts in like schools or daycares because it's passed via the fecal-oral route. That sounds gross, I know. People are just literally going on eating feces, but basically what happens is someone doesn't wash their hands well from using the bathroom, or they're changing diapers and don't wash their hands well, or like it gets spread somewhere, touching a doorknob, touching a faucet, whatever, what have you, and then eventually people touch their mouth, their face, and it gets spread that way. So that's the fecal-oral route, okay? And kids are nasty, right? Kids don't wash their hands, they're in everything, they touch everything. So it can get in contaminated food and water as well, just from the lack of cleanliness. So like a lot of kind of, gross restaurant chains that aren't super great, maybe have a low health, what are those health screenings? Like the health code department that checks them out, maybe have a low score in that. I forget what it's called, where the health department gives them a score on how clean their facility is. The workers maybe aren't cleansing things very well or washing their hands, and it gets spread to customers. So contaminated food and water. There is no chronic form, so that's good. This is usually a very acute illness. I think A for acute, hepatitis A, acute, that's how I remember it. They have a quick infection. Usually there's a complete recovery, and then people get over it. There doesn't cause any chronic problems. They aren't carriers. They don't have to deal with this beyond the acute infection. Hepatitis B is spread via the blood. I think hepatitis B for blood, okay? So easy to remember. Blood also from like sexual contact. So blood and sexual contact, semen, vaginal secretions. This can also be passed in childbirth. So if a mom is infected, like if I had a baby and I had hepatitis B and I had a vaginal delivery, you could potentially pass it to your child in that way because of passing through the vaginal secretions. Sharing contaminated needles is also a big one. So, IV drug users share contaminated needles. You can get hepatitis B. Also places, this is why it's important to go to places that are nice and not go to some, dark alley to get your tattoos done or your piercings done, because contaminated needles can also be passed that way. And Kelly's laughing at me. Hey, it's also life advice time. Check out the place.
Any one of these women going through a dark black
I don't know. I mean,
Your tattoo.
economic times are tough, you know. I'm just saying. The problem with hepatitis B is that this one can potentially become chronic. So there are chronic forms of this that cause permanent damage to the liver. So hepatitis A doesn't have that problem. Hepatitis B does. Okay. Now hepatitis C, very similar to hepatitis B. This one is also spread via the blood and body fluids, semen, vaginal secretions, the kind of the same way. This one causes very, very acute liver disease. It's one of the most common, what does it say in the book? One of the most common viral infection causes of death. So this one often requires transplantation for the liver. So this one's the most severe. Okay. Any questions so far about hepatitis?
Yeah, I have a what if question. Like, what if there's blood and like you just like touch it, but your blood doesn't touch that blood? Can you still get hepatitis B?
So it has to mix in with your blood, right? So the blood would either have to touch one of your mucous membranes, like in your nose, your mouth, vagina, anus, but just touching it with like a finger, unless you have a cut on your finger, you're not going to get it, right? But still, I wouldn't recommend touching blood with your hands. Another good point you brought up is that people ask about like saliva or kissing. It is not passed through casual contact. So like you're not going to get it by sharing a cup with someone, right? But you could get it from like sharing like a toothbrush or a floss, because if you floss and your teeth bleed a little bit, like that blood can stay on that floss, and then if you share the floss, that's kind of a gross thing to do anyways, but married people might share floss, I don't know, or a toothbrush. I just mentioned it because it's in the book, okay? So if there is any potential for blood getting on something, you can get it, but it's not just passed via saliva, unless there's blood in your saliva. Does that make sense? So you're not gonna get it from kissing unless someone has like a sore on their mouth. You're not gonna get it from sharing a cup unless someone is like bit their cheek and now you see what I'm saying?
Yeah.
So it has to be blood mixed in with something, okay? Here's a picture of jaundice, very yellow. Yeah. Did you say something? Yeah, it's bad. These are toxins that didn't get filtered out when the liver is not doing its job, okay? All right, cholelithiasis. So whenever you see the word cola is referring to the gallbladder, okay? That's the medical terminology for the gallbladder. So like hepatitis is for the liver, cardiac is for the heart, cerebro is for the brain, so cola is for the gallbladder. What's happening here is that there are gallstones building up inside the gallbladder, usually related to a high-fat diet or high cholesterol. That these little stones just form inside the gallbladder. My dad actually had this. He had a really bad. He loved to have like steak every day, steak and potatoes. And then he got gallstones, had to have his gallbladder removed, and then completely changed his diet because he got scared. So that's generally what it's from. Pain is going to be in the epigastric region or right upper quadrant, because that is where the gallbladder is. If you remember, like you can go back and look at the picture. The liver was like it was like right under the liver, and the liver was on that side. Clay-colored stools, again, is another one. So the clay-colored stools are common with hepatitis and this one. So that's kind of a giveaway. Talked about the etiology. Let me show you a picture, actually. So here's the gallbladder. It secretes like various enzymes and things that help with digestion. So the gallbladder makes those enzymes, and it goes down the duct and goes into the duodenum. So it kind of secretes those things, and it goes into the duodenum to mix with the food to help it digest. Okay, but if there are these stones that get built up, they can get stuck inside the duct and cause a blockage. Okay, now if that happens, then you're gonna have cholecystitis, which is inflammation of the gallbladder. Okay, so cholelithiasis is just the presence of gallstones. Cholecystitis is the inflammation itself of the gallbladder. Just like diverticulosis is the presence of diverticula, diverticulitis is now that they're inflamed. Okay. Diagnosis usually is done with just an ultrasound. They can see the stones really well. They usually just remove the gallbladder. It's called a cholecystectomy because you can live without it just fine. There's also the option of lithotripsy. Lithotripsy is basically they send shock waves, sound waves, onto the gallbladder, and it like vibrates the stones really, really fast with the sound waves, and it helps to break them up into smaller pieces. So it makes them easier to pass through. So like if there's like a really big stone, it can break them up into really tiny pieces so that they're able to be passed through without having to remove the organ. They also do lithotripsy with kidney stones as well, but we'll talk about that later when we get to the urinary chapter. But yeah, so that's what's happening. Any questions about cholelithiasis? No? All right. So pancreatitis is inflammation of the pancreas, and this also has a very similar etiology. So let's look at the picture real quick. You can see it's kind of the same picture as this, but just a different view. So the gallbladder is releasing those stones, but you'll see that it has a branch here, where like one branch goes into the duodenum and the other branch comes from the pancreas, right? So the pancreas also releases enzymes, amylase and lipase, to help with digestion. And if the gallstones are blocking here, then all of the enzymes from the pancreas are going to get stuck and can't come through either. Does that make sense? So it's like blocking both the gallbladder and the pancreas. That is one potential cause. There are other potential causes. Alcoholism is a big one. Various different things, but those are like the main reasons. Pancreatitis is really bad. It's super painful. Like I've taken care of patients with pancreatitis, and it is miserable. Like they're in such extreme pain because basically what happens is like those digestive enzymes, they get stuck in the pancreas rather than being able to exit out into the intestines to go help digest the food. So basically what ends up happening is that those enzymes start digesting the pancreas itself, right? Because they're really strong, they're meant to like digest food, but if they're stuck in there, the pancreas starts digesting itself, which is very, very painful, very excruciating. It's really bad. So the pain is gonna be really awful. Interestingly, the pain is worse when lying down and when walking. People say the pain is better if they sit and lean forward. No idea why. Chronic pancreatitis can lead to diabetes mellitus. And let's talk about that. So if the pancreas is ultimately digesting itself, it's going to be damaging it, right? So like it's not going to be able to secrete insulin because it's damaged. And insulin helps with the blood sugars, right? So if your pancreas is busted, it's not able to secrete insulin anymore. That's what leads to diabetes, right? So it has nothing to do with like their diet being bad or like being obese or eating too much sugar. It's just that their pancreas ate itself and it doesn't work anymore. So it's like they're functionally a type 1, which means that they're not able to secrete insulin anymore. Does that make sense? All right, so diagnosis, they're gonna have those elevated pancreas enzymes, right? Because when the pancreas is in distress, it's going to release the lipase and the amylase, just like the liver secretes AST and ALT, and just like the heart releases troponins when it's in distress, okay? Hyperglycemia might also be noted, and hyperglycemia means high blood sugar, right? And why is the blood sugar high? What's not being secreted? Insulin, right? So insulin helps lower the blood sugar. If the pancreas can't make it because it's damaged, then your blood sugar is going to be super high. Does that make sense? All right. Hospitalization is going to be the treatment because it's really bad. These patients need a lot of care. So we're not even going to go into all the treatment because it's more than you're going to need to know. All right, I think this is our last one. All right, so celiac disease is basically the medical term for gluten intolerance. This causes damage to the small intestine. So symptoms of this, weight loss, and the reason for the weight loss is because they are going to have essentially malnutrition, okay? So they're having the gluten intolerance, so they're gonna have like an allergic reaction every time there's gluten in the system. And so they're gonna have all this going on in their small intestine, so they're not gonna be able to absorb the nutrients because they're just trying to get it out as quick as possible to get rid of the offending substances. And so your small intestine's like, its job is to absorb nutrients, and if it's like trying to push everything out, it's not gonna be absorbing the nutrients, you're gonna have malnutrition and weight loss, okay? So also with that, diarrhea, flatulence, just because you can't tolerate it. It's kind of like a, what's it called? Lactose intolerance. People have the same kind of symptoms: diarrhea, flatulence, distension. Dermatitis of the skin is one of those different symptoms that's different from the other ones. So for whatever reason, people who are allergic to gluten don't just have GI issues, they also have skin issues. So their skin also reacts badly to gluten. And this might not necessarily be everyone, but several people do. They have like just weird rashes, various parts of their body as an allergic reaction to gluten. The stools are going to be large, pale, and greasy, and they're going to have, the malnutrition and weight loss. Gluten is found in things like wheat, barley, and rye, and other things, a couple things mentioned in the book. So a lot of breads are going to be off limits. Diagnosis of this is just going to be a biopsy of the small intestines just to make sure there's not some kind of weird cancer going on. And then basically the way people know is that when you go on a gluten-free diet, your symptoms get better, right? So that's kind of a telltale, like, oh, well, you have gluten intolerance. And that's basically the only treatment really, is just to go on a gluten-free diet and just manage your symptoms. People who avoid gluten, they don't have any problems. So there's no other treatment needed. And that is that for the digestive. Yay. We have, like 15 minutes left. Would you guys rather I do some Jeopardy questions over digestive, which we just talked about? Or would you rather do some Jeopardy questions of respiratory, since we're not doing an in-class lecture, or would that be kind of useless because many of you haven't listened to the lecture yet? I'll let you guys choose. Raise your hand for digestive. 1, 2, 3, 4, 5, 6, 7. Okay, basically everyone. All right. If you do have questions about respiratory after you guys listen to it, just send me an email and I'll try to answer as best I can. All right. Let's do some Jeopardy. We'll just do everyone all together. We won't do teams in here. Everyone's on one team, okay? So we'll just go in order, like this way, and just everyone just answer. You want to go first? Symptoms for 5? All right, literally I just copied and pasted the symptoms to see if you guys figure it out. Wow, that was quick. I haven't even read it yet. Hold on.
Well, we just did.
Yep, okay. Nice job. The dermatitis here should be the one that gives it away. So good job. All right. Who's over here? Sarah. All right, so loss of appetite, losing weight, nausea, vomiting, indigestion, abdominal distension, edema, bleeds and bruises more easily, jaundiced skin, which disease? So kind of the skill as you look through these is trying to find the ones that kind of stand out, because a lot of the digestive symptoms are going to be the same. So the one that stands out here is the jaundice and the bleeding and bruising more easily. So that only goes with one thing. I guess we can just have anybody answer if anybody gets it. Let's see. Nice job. So yeah, as you kind of like a test taking strategy is to kind of like look for the ones that jump out at you that are different, because a lot of signs and symptoms are going to be very similar. Okay, so nice job. All right, Alexis. All right, which disease is caused by relaxing or loosening of the lower esophageal sphincter? Anybody? GERD, yep. So remember that the loosening of that sphincter is what allows that stomach acid to reflux back up into the esophagus. All right, who's up? All right, abdominal pain, nausea, vomiting, weakness, profuse sweating, fever, not wanting to move, and hard, rigid abdomen. So which ones here stand out that are different? Which of these symptoms stand out that are different from like the normal hard, rigid abdomen, and possibly also not wanting to move? So the rest of it, nausea, vomiting, blah, 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 abdominal pain, all of them have that, right? It's not IBS. Yep, peritonitis. Just remember that big swollen belly that looked like she was about to have twins? That was just the inflammation. Very, like, the abdomen is like a solid rock to the touch, okay? There you go. All right, who's up?
I'll do etiology
Etiology for 4. Which disease is characterized by possible inflammation anywhere from the mouth to the anus?
Crohn's.
Nice job. Crohn's disease. Beautiful job. All right, over to you.
Symptoms for GOD.
All right, bloody, mucousy diarrhea, abdominal cramping, urgency to defecate, frequent stools, 10 to 20 a day.
Ulcerative colitis.
Let's see. Nice job. And, oh yeah, here we go. I guess I don't have to do that. All right, Hannah. For what? All right, which enzymes will be elevated in cirrhosis? Yep, the AST and the ALT. Those are those liver enzymes because that liver is in distress. For what? 3. Or which disease is caused by Clostridium difficile?
That's a long one.
Mm-hmm.
This starts with P.
Yeah.
Pseudomembranous.
We call it C. diff, but what's the long name of it?
Pseudomembranous.
Yeah, that one. Pseudomembranous enterocolitis. That's what it is. All right, Jada? What may be required if a portion of the bowel is surgically removed? Yep, it's that ostomy bag where it's poking out the stomach and they have that little sticker bag that collects everything. Yeah. All right. Mm-hmm.
Treatment for too much.
And what is the name of the procedure that drains excess fluid accumulated in the abdomen from ascites? Yep, paracentesis. So they stick that needle in and it kind of drains all that fluid out, like remember that big belly? So ascites is common with cirrhosis and peritonitis where they have just all the swelling and edema and it's like really painful, so they got to get that stuff out. So a little needle drainage bag, paracentesis. Okay, let's just start back at the beginning, I guess, so go ahead.
Okay. Let's do treatment for 4.
All right, a truss is useful in the treatment of what? What was a truss?
Abdominal hernia.
Yep, it was that brace. Remember that picture of that man, like with the brace around his abdomen to help kind of press the hernia back in, right? So that's what it tries to help fix. All right.
Treatment.
Or which 2 drug classes help decrease the amount of gastric acid produced?
Was that BPI and H2 blood?
It was. Yep, those 2 drugs, which are the treatment for a lot of different things, basically just reduce amount of stomach acid. All right.
Symptoms.
All right, belching with burning, heartburn, reflux of bile, worse when lying down, and tooth enamel erosion. It is GERD. Yep. So remember, it's like that constant reflux of stomach acid is going to cause problems with the teeth eventually. This is also, people with bulimia also tend to have tooth enamel issues because they're constantly having it coming out. And it's also worse when lying down too, right? Because that esophageal sphincter doesn't work. So if you lay down, the stomach contents just come right up the esophagus. It doesn't have to work against gravity. All right, here. All right, stomach ulcers are often caused by which causative agent? What's the name of it? So that is what this is. So stomach ulcer is a gastric ulcer, but what causes them? Yeah, that is a drug. What I'm asking about is the causative agent, like the pathogen itself. When they say a causative agent, they mean like a virus, a bacteria, or a fungi. H. pylori. The H stands for Helicobacter. It was funny because I had a student that called it helicopter pylori. It's Helicobacter, but yes. So H. pylori is a bacteria that causes those ulcers. All right, which condition can be caused by constipation, straining, pregnancy, or anything that increases pressure, thereby damaging the vessels? Yep, good job. Hemorrhoids. All right, which disease is characterized by healthy liver tissue being replaced with scar tissue and fibrotic cells? Correct, that is cirrhosis. Hannah? All right, elevated lipase and amylase are associated with which condition? What organ secretes those? Someone said it.
Pancreas.
The pancreas secretes those. So which condition? Pancreatitis, right? So amylase and lipase are digestive enzymes, right? Like your food has to be digested, and your pancreas helps with that. So it secretes these. Lipase helps break down lipids, and lipids are fats. So lipase, right, helps break down fats. And then amylase, honestly don't know what that one does. It breaks down something. I don't know. But it helps with digestion. So it also, yes?
Does the pancreas release lipase and amylase, or?
Mm-hmm.
Oh.
Yeah, the pancreas has two functions. It has an endocrine function, secreting insulin to help with blood sugars. It also has the exocrine function, which is with digestion, so it releases these as well. It also these will be elevated if the pancreas is in distress as well. All right, I don't know whose turn it is. I think it's Olivia.
Diagnosis for
Which diagnosis involves pain at McBurney's point? McBurney's point was a very specific point on the abdomen. Appendicitis. Nice job. All right, Jada. Which diagnostic test involves the insertion of a camera through the esophagus? What was it? I don't know what you said, but I think you said endoscopy. So an endoscopy goes through the mouth and can go to the through the esophagus, the stomach, the duodenum, the small intestines. A colonoscopy goes in the back end, right up the colon. And look at that, we have just enough for everybody to go twice. Perfect. I guess you want this one. All right, what is the purpose of lithotripsy? What does lithotripsy do? Anybody? Yep, so it is a treatment that involves sending sound waves and it's kind of like it shakes them real good and helps break them up into smaller pieces so they can be passed through and not cause a blockage. Used for gallstones, also kidney stones, pretty much any stones that shouldn't be there. But we just finished just in time. You guys we are done for the day. We don't have another lecture until exam, so please message me if you have questions. Don't put it off to the last minute, because if you message me at like 1 in the morning before the exam, I'm gonna be asleep. Okay, so I won't be able to help you at that point. It'll just be survival of the fittest. The pat. Okay, I have extras here. I was wondering why there were so many.